Dr. Robert Groysman, and I help people with long COVID and COVID related vaccine injuries. Amira will be joining us. I'm just not sure when. And I was actually expecting a couple of additional guests, but I don't know who's going to be joining us. So I wanted to first open up the forum for any questions. If you have questions about long COVID, about management of long COVID, COVID vaccine injury questions, or MCAS, which is Mast Cell Activation Syndrome, chronic fatigue syndrome, or basically anything related to these topics, I'm all ears and I'm ready to discuss. Until we get our first question here, we can talk about one of the latest studies. But let me take a quick look here at our chat. Can long COVID cause tinnitus by Sarita? That's a very good question. And I have seen tinnitus associated with long COVID. Now, whether it causes it or not is kind of a loaded question. There's a correlation, but we don't know for sure if it's a causation. Correlation just means two things tend to occur together, but neither one of them causes the other. So that's kind of the main difference between something that correlates versus causes something. I wanted to make sure that everybody can hear me, and if you're watching, you're able to ask questions and comments first before I go on. Okay. Someone is asking, how do we fix the gut if it is the main culprit to so many symptoms? Well, that's kind of a loaded question as well, because there's several different things that are wrong with the gut. So what COVID tends to do, and I'm talking about the acute infection now, what it tends to do is tends to change the microbiome. That is the bacterial, viral, and yeast inhabitants of your gut. But our microbiome is not just limited to our gut. Pretty much every square inch of us has something living on it, microscopic. So our skin, our lungs, our hair, including our eyelashes, inside our body and outside our body, there's kind of different biomes of different species. So it doesn't just affect the gut; it affects others as well. But why is the gut so important? Because there's so many different axes between the gut and other organs. Some of the most important ones are gut and brain. There's also gut and lung, gut and liver, gut and kidney. And this is a two-way communication. Between the gut and the brain, a lot of the communication occurs through the vagus nerve, directly through the nerve, or through neurotransmitters. Another thing that happens when the microbiome is disrupted, that means that the concentration of bacterial species changes from what it was, is you can form what's called leaky gut. Now, I know it has kind of an ambiguous sounding name to it, but really what we're talking about is a breakdown of the tight junctions. So between the endothelium inside your gut, the endothelial cells, and the blood vessels, there are tight junctions that basically prevent any toxins or any inhabitants from leaving the gut and going into your bloodstream. But when the tight junctions are disrupted, that's no longer the case. You really have tight junctions in two places. One is in the gut, and the other is in the brain. In the brain, it's called the blood-brain barrier, and in the gut, I guess it's called the blood-gut barrier. So it's kind of difficult to in a short period of time to say how we fix the gut, but in general, what we want to restore is the homeostasis, the equilibrium that normally exists in you in particular. Everybody's gut biome is slightly different. We have different species in there. We get them when we're born, and they're modified over the course of our lifetime. And your body kind of expects certain nutrients and chemicals and vitamins coming from your gut. And when that's no longer the case, you start becoming sick. Now, this is not just for long COVID. Many chronic illnesses have been implicated originating from the gut. So the short way I can answer that is restoring the equilibrium in your gut is what we want. Next question we have is, have you seen reactivated Lyme? Yes, I have, but it's kind of a difficult question to answer because many people don't even realize that they have Lyme disease. Because if you didn't get the rash and it just happened to go into latency early, you may not have had any symptoms or anything to tell you have Lyme disease. And unless you've got tested, you wouldn't know. Lyme disease tends to occur in certain pockets geographically. Now, there's different kinds of Lyme disease. There's ones that occur in the United States. Obviously, the very first case was in Connecticut, which is where the name came from. But East Coast is kind of a hotbed for Lyme disease, but it technically can happen in any state. Yes, it's going to be extremely unlikely in cold states like Alaska, but it can technically happen in any state. If you've been infected and it's untreated, it doesn't just go away. It becomes latent or dormant, and it can come back anytime from 1 to 20 years later. And until it's treated, it really is just there. It's much tougher to treat Lyme after it's become latent. These little bacteria, they're called spirochetes, Borrelia, and they kind of look like a little corkscrew, and they enter cells and they hide out in your cells. So even if you take antibiotics, the antibiotic can't reach them inside the cells. It can only reach them in your bloodstream. So once they've established themselves inside cells, they're a lot more difficult to treat. I don't think Lyme is as common as people think it is. It's not like it comes from nowhere. You had to have had the initial infection first. But like all spirochete-based infections, it has the potential to become latent and stay in your body for a long time. I hope that that answers your question. And yes, I have seen reactivated Lyme, but like I said, it's mainly if you've had it in the first place. So it's different from a virus. Let me take a look at some more questions here. And we have a lot of them. Give me one moment, please. Am I sounding okay and everything? Is the voice transmission going well? is MCAS being activated by the virus? So it's not really an activation. We don't have a definitive cause for MCAS yet. What it is it's an inappropriate degranulation of mast cells. Now, these cells are kind of like a lot of small factories that contain a lot of pre-made and built-up bioactive substances. Some of them are not so nice, but that's a good thing because they're meant to destroy pathogens and anything that doesn't belong in our body. And they're only supposed to degranulate when they get a certain, basically, signal from your body. And during MCAS, that happens at a drop of a hat. And when you have a mast cell degranulation, that can lead to anaphylaxis, and obviously that's very dangerous. And it's basically dumping of all of those chemicals into your body at the same time, in sync, and that leads to many problems. So the virus really can't activate MCAS because MCAS is not something to activate. It's a dysregulation of your immune system or part of the immune system. Okay, let me take a look here. So Andrea is asking about long COVID presenting as ME, which is myelopathic encephalopathy, which is part of the chronic fatigue syndrome. So I do believe they're related. So while chronic fatigue is obviously not caused by the COVID-19 virus, the post-viral syndrome is very similar to chronic fatigue, and I think the presentation is very similar. The post-exertional malaise (PEM), I do think is related to mitochondrial issues, specifically mitochondrial dysfunction, and I wanted to talk about that initially. But this is a different type of problem with mitochondria than the primary mitochondrial disorders. Now, some people, some kids, they're born with a primary mitochondrial problem. They have a lot of different names depending on the type of mutation it is. And those are much more difficult to manage because it's a genetic problem with the mitochondria. So mitochondria are kind of neat little organelles. So we think that they originally were independent. They weren't part of our eukaryotic cells. And they actually have their own mitochondrial DNA. And that's how they make more of themselves and make some of the proteins that are involved in the mitochondria itself. A lot of those functions have been taken over by our cells in their DNA structure in the nucleus. But it still retains some of the primordial parts to make mitochondria for itself. I can address mitochondrial treatments and stuff, but maybe at a later time. There's different kind of ways to tackle mitochondria issues. And remember, mitochondria don't just make ATP and energy; they're also responsible for many of the metabolic functions that your body needs to do, and that's converting one molecule into another. So what I think is going on with long COVID is there's multiple causes at the same time, and they all compete in different people, what percentage it's impacting you specifically. And the three that I think are most commonly involved are dysautonomia, gut dysbiosis, and mitochondrial dysfunction. Now, in depending on which strain you had, depending on your metabolic state and your immune system function, these are going to have different impacts on each individual person. So that's why I think there's a huge variation in what symptoms you have, and there's 200 plus symptoms reported between everybody with long COVID, and the severity of it, how severe it's going to be. Now, there's a theory out there that if you start out with a disrupted gut microbiome, now that could have happened from prior infections, from prior antibiotic use, from chronic illnesses. There's many different reasons for your microbiome to be disrupted. If you already start out with disrupted microbiome, you're more likely to have more issues with long COVID, and you're more likely to get long COVID. Somebody is asking about neurologic symptoms, and I apologize right now if I miss any questions. I'm doing my best to make sure I catch everybody, but they're coming in pretty fast, and I may miss a few, and I will go back and look. But somebody's asking about neurologic symptoms after COVID. So I believe that neurologic and psychologic or psychiatric are the most common subvariant of long COVID. And that typically involves the chronic fatigue, the brain fog, the anxiety, and the neuropathies. And neuropathies can show up in a lot of different ways. And what is a neuropathy? It's really inflammation or irritation of nerve tissue, so that it's, instead of conducting or signaling when it gets a signal, it's just signaling all the time. And when it does that, you're feeling things like pins and needles, pain, things like crawling or ants crawling. Diabetics tend to have that kind of symptom all the time in their legs specifically, because it's the furthest away. So if you have it in your chest, it could feel as chest pain, or it could feel as vibrations in your body. If you have it in your ear, it could be fullness, or it could be tinnitus, or you can have hearing issues. If it happens in your eye, you can have visual disruptions, such as blurry vision or issues with light sensitivity. So those are kind of the main things. If it's also involving the autonomic nervous system, which it often does, you'll have issues with POTS or heart rate, tachycardia, palpitations, things like that. How to deal with palpitation, Fitnet is asking. Due to long COVID, all heart exams and tests come out normal. Just mild mitral valve prolapse. Well, you still need to find out why you're feeling palpitations. So oftentimes palpitations are kind of a knock, so to speak, that happens in your heart. So it's similar to an engine knock, like an early misfire. So you'll either have an extra beat, and that can come both from the ventricle or the atria, because it's more irritable or excited. And I've felt these when I had an all-nighter and a ton of caffeine to keep me awake. You start feeling kind of extra beats or ectopic beats. That's the most common reason for palpitations. But you can also have an arrhythmia where your heartbeat is abnormal and irregular, and that can feel funny in your chest. So first things first is figuring out what the palpitations that you're feeling actually are. And the easiest way to do that is to do a what the heck is it called? It's basically an EKG, but it stays with you for 24 hours or 3 days. I'm blanking on the name for it for some reason. It'll come to me. That's what you want to do to find out what is going on with your heart. Why are you feeling the way you're feeling? So somebody's asking about T3 or reverse T3. So reverse T3 occupies the receptors in your thyroid, but it doesn't activate them. That's the interesting thing. Halter, yes, thank you. That's what I was thinking of. Halter monitor. Thank you, Marina. Sorry, I lost my train of thought. Oh, right, reverse T3. So most commonly where I see increased reverse T3 actually is with the use of some of the synthetic thyroid medications that are used for low thyroid. I'm not going to mention names because of copyrights, and I don't want to create a liability here. But that for me personally, when I've been testing patients, where I see the reverse T3 increase is not necessarily with long COVID, but if you're taking a replacement medication that's not natural, let me put it that way, and you're taking it for low thyroid to replace your thyroid. And part of it or all of it is being diverted into reverse T3. So reverse T3 has another function, and it actually decreases T4 to T3 conversion. So it kind of is a double whammy. Do I think the mitochondrial dysfunction is reversible? Absolutely. Absolutely, I think it's reversible because this is a functional problem. Not functional like imaginary in your brain, like functional neurologic disorder, okay? I'm talking about function in the fact that it's dysfunctional. It's not a genetic problem with the mitochondria. There's something interfering with mitochondrial function. In other words, it's either interfering with the metabolic part, which is where the electron chain transfers energy from fuel into ATP. So that's part of the electron chain. And that's what generates energy. But you also have to remember that our body is not perfect. It's probably the most efficient engine we have. That includes anything that's man-made. But whatever your body can't convert to energy is dispelled as intermediates or heat. This is actually what's responsible for maintaining our body temperature. So, we're warm-blooded, and we need to burn fuel constantly, even while we're sleeping, to maintain our temperature within 1 or 2 degrees of 98.5 degrees Fahrenheit. The other part, here's Amira is coming on. Let me bring her on. Hey, Amira. Doctor. Let me just finish my question, and then I'll see what's going on with you. Give me 1 sec.
Sure.
The second part of what mitochondria does is it methylates, it sulfonates. I mean, there's all these processes that happens, and there could be a problem with that part as well. There's kind of 2 ways to look at it, but I absolutely think it's reversible. I think it's treatable, and I think we're going to get very close to getting people back to normal from the mitochondrial dysfunction, at least, and from the dysautonomia. Now, the gut microbiome thing, that is a little tougher and longer. It's a longer process. Do I think it's treatable? Yeah, I do. I do think it's treatable, but like I said, the order matters. What you do, how you do it, the quality of the products you take, natural preferred over pills or capsules if you can. But yes, I do think long COVID is beatable, and I do think we're going to beat it. So, Amira, how is your day
going? I don't know. I'm using this phone for the first time to join into the restream, so I hope you guys can hear me okay. I'm just using the actual audio in this phone,
Yep, I
And
didn't tell them why you couldn't be here at the beginning, so
oh,
you may want to go ahead and tell them what's going on.
yeah. Um, uh, you know, when you have long COVID, a lot of the patterns I see is folks are very sensitive and can pick up on smells better than anyone else. And I noticed uh, in the place we're staying at that I could smell this like gas type smell. And, it was like every day, I'm like fighting with my kids, not bad fighting or whatever, but like I need to open the window, you turn on the fireplace. I can't breathe the minute it comes on. It's like something, it's not a normal like gas fireplace. Or even a barbecue, that I can tolerate. But this would come on, and then I'd be like, my chest hurts, my heart hurts. And it's been a while since my heart hurt like this. And I have an appointment tomorrow, actually. I tried to get in with the cardiologist sooner. It'll be
Hmm.
30
Are you
days.
outside?
Pardon?
Are you outside?
No, I'm in a room and I have the window open.
Oh,
I wanted to make sure to say hi to everybody, and so it's kind of like really cold. But uh, I was in the process of tearing down my computer. My laptop is not like a tiny laptop; it's big,
sure.
uh,
Well, it's
big
fine. We
machine.
can hear you just fine.
Yeah, so I didn't want to miss out on saying hello to everybody, but you tend to always second guess yourself when you know it is rare to find a doctor like Dr. Groysman who believes you when you say something. I too have some of that medical PTSD and second guessing of myself, and even your loved ones who've known you 20 years can say something like, really, are you just whining or whatever? But then they go and step into another room, and there's like no hovering of that gas type smell. They can notice the difference. And I
Hmm.
was like, uh, it explained why my migraines were getting worse, my chest was hurting more, my heart was hurting more. And you wonder, what kind of monitors do they put in these buildings? That we're better monitors of our environment than
Yeah, I
the
mean
electronics.
they don't look for natural gas or anything in buildings. Just
Yeah.
it's
And
not something that's built into the building.
yeah, and the mechanic that came to the room was like, I think it's the ceramic pieces that are in there, but he can't service anything. So I'm like, okay, the only option is to move to another room. And when you have kids on the autism spectrum, they like to know how things are going. They get their routine.
How's Bobby handling all this?
He's a trooper. He handled it pretty well. And but prior to that, he and I were knocking heads because he was getting cold, because of the temperature dysautonomia, the temperature changes. And I was like, I can't breathe. I'm opening the window. He's like putting the fireplace on. I'm like, this is just like um, a, a a battle we couldn't win. And finally, he stepped out and went for a walk with my husband. And by the time they came back, they had realized when they walked into the room, they could smell that difference. It's just when you know, I guess you get used to something, some folks, but for me, my internal monitor of my heart hurting and my lungs hurting, and they haven't hurt like that in a while, and the headaches getting worse. And you would know better, Dr. Groysman. I don't know what people are supposed to feel when they get like carbon monoxide or any of those
Not
chemical
well.
sensitive?
Carbon monoxide binds about 10 to 20 times stronger to hemoglobin than oxygen.
Oh gosh.
So you have so many positions on your hemoglobin throughout your body, and they're slowly being replaced by carbon monoxide, and oxygen can't bind. So this is a reason. This is a good reason to use hyperbaric oxygen as an example,
Ah,
because guess what? How are you going to get that carbon monoxide away from your hemoglobin? It likes it a lot. They're
yeah.
best friends.
You're gonna have to
And,
push it out.
they like it so much. It likes it so much that oxygen comes by and say, "Can I have this dance?" And the carbon monoxide says, "No, screw you, go away. I'm dancing right now." And you could see kind of what happens after a while.
Gotcha.
You have no oxygen carrying capacity. So this is kind of a number one reason for using hyperbaric oxygen. Is
Ah,
that you have to have higher pressure and higher percentage, and you push that carbon monoxide off and you breathe it out.
gotcha.
That's really the only way.
That's
Um,
something. I need to. Well, when I go to the
but
my
that's only if
follow
you're
up.
super symptomatic or you're having
Yeah.
problems. But you'll know.
Yeah.
You will know. You'll be short of breath.
I was using an inhaler. I was like down to the last, it tells you how many are left. And I
Yeah,
go,
that's not going to help, unfortunately.
yeah,
You really do need a hyperbaric treatment for something like that. But
hopefully,
that's only if there's significant amount of carbon monoxide
yeah,
bound to hemoglobin, and it will separate over time. But
gotcha,
if there's too much, then yes, you need to do a hyperbaric ASAP, and you'll be short of breath.
gotcha.
You'll have a really hard time catching your breath, and oxygen is not going to help.
Well, I'm glad something was figured out, I'm just
Well,
thinking,
so let me take a look and see what else is going
yeah,
on here.
you mentioned some about microbiome before I hopped on.
Yeah, I don't really want to. I know somebody asked about the microbiome protocol. It's going to be too much to really try to explain in a podcast type thing.
Right.
So I'm kind of going back because we have a lot of questions.
Sure, sure. I can't, the one problem with it being on the phone, there is like
That's okay.
no way I can read the questions, so I'm dependent on you, Doc.
Somebody is asking about getting steroid-induced myopathy. So this is one of the big problems with trying to treat long COVID with steroids. High dose steroids, they may make you feel good for a while,
Mhm.
but they cause a lot of complications. And one of them is induced myopathy.
Interesting.
Um, it's
So,
damage to the muscle.
some folks have been mentioning that they can't tolerate steroids.
Well, I mean, our bodies need some steroid, obviously,
Right.
for managing stress. Okay, and I'm not
Gotcha.
talking about like, you're nervous and you're stressed out. I'm talking about body stress. So what
Okay.
stresses our body out? Well, the most common thing that happens every single day is just waking up. Going from a deep sleep to
Mhm.
being awake is extremely stressful on your body. And that's because it has to reactivate all of the things that get you going. Um, while you're in deep sleep, your heart is working slower and softer, your breathing is slowed down, even your temperature control, your metabolism is low. So your temperature can drop by a degree or two. And
Yeah.
getting all that kind of back to normal every morning is incredibly stressful for your body. If you have infections, that's stressful for your body. If you're having chronic illness, that's stressful for your body. So yes, you do need some steroid, but just like everything else, there's a balance.
Gotcha.
If you go too low, you have issues dealing with physical stress. If you go too high, you get complications and problems from that.
Do you think it has anything to do with maybe the way they're delivering the medications sometimes?
It's all about absorption.
Yeah.
I mean, obviously, things like intravenous is going to have more absorption than topical
Gotcha.
or oral. But it's really how much you're getting over how long a period of time. Back in the day, they used to treat tuberculosis, which was called consumption. This turn of the
Oh.
century, they used to have these sanitariums where people would go to recover, convalesce from
Mm.
tuberculosis. And the best way that they figured to treat tuberculosis was with steroids, high dose steroids. And the people felt great. They started gaining weight back, they got the color back in their cheeks. Meanwhile, it was basically fueling the infection that was going on. And many of them didn't make it because they died or succumbed to the tuberculosis.
Interesting.
Because you're suppressing your immune system.
Yeah.
Steroids. So they looked good, but when you opened up the hood and actually looked what was happening inside, their lungs were looking like Swiss cheese.
Oh no.
So, live and learn.
Yeah.
Regarding the
What's the
myopathy, I have to double check if it's permanent or temporary from corticosteroids. Some myopathies are permanent, some are not. So I don't want to give you the wrong answer. So let me do a bit of research on that.
Yeah. I do know that there was one medication rheumatologists were using to help modulate the immune system, the hydroxychloroquine or Plaquenil, and you had to make sure to
Now, Plaquenil is hydroxychloroquine. That's the medicine that was first proposed to treat long COVID,
yeah,
being an
and
modulator.
yeah, and it's been helpful to quite a few folks. And the key thing that the rheumatologists mentioned are to follow up with your eye doctor to keep an eye out for your eye blood vessels. And if you get an unusual side effect of seeing differences in the like red colors or the
Yes,
changes in
hydroxychloroquine can cause a retinal issue with the blood vessels. So you
gotcha.
really should have that monitored. That's why I'm not a big favor of having people kind of get medications from alternative sources
Right.
or manage themselves, because some of them are safe, but some of them have pretty serious side effects.
Yeah,
And if you don't know what to look for,
exactly.
and you get this, for instance, with hydroxychloroquine, it's a permanent thing. It doesn't go away. So if you notice it too late and you don't stop the medication,
Right.
you could actually become blind from it.
Yeah.
And this is irreversible. So um,
And
yeah.
isn't it also treat no wait that's ivermectin, river blindness, another autoimmune
Well, I
type
thought
condition?
blindness was caused by a parasite.
Yeah, but it they were using the medication to modulate the immune response. The body was
Sure.
like
Yeah, well,
over.
there's a few of these medications.
Yeah.
They're mostly derived from plants or
Yeah.
actually fungus. A lot of times
Interesting.
fungus, and some of them are actually derived from bacteria,
Hmm.
which is kind of interesting. But somebody mentioned on Facebook rapamycin. That's an interesting medication. It's
Yeah.
normally used to prevent rejection from kidney transplants, and you can
Okay.
use it for other transplants, but it's immune modulating.
And
And one of its kind of
with the liver, doesn't it help some folks with the liver inflammation?
I'm not sure about the liver, but I know it's being trialed for some mitochondrial issues,
Okay.
because it lets certain cells go through apoptosis, which is kind of a non-inflammatory destruction of the cell, or autophagy.
Okay.
Whereas without it, there's a component called mTOR. It's a signaling mechanism,
Mhm.
and it gets overly activated, preventing the cell from actually dividing, or actually causing it to divide or not die off. So you have kind of these zombie cells, as you say.
Gotcha.
So by introducing an mTOR inhibitor like rapamycin, there's a potential to let the bad or sick cells die off. It's still very early in the research phases, so I wouldn't necessarily recommend going out and getting a prescription of this, but
Right.
this definitely looks promising. But it is an immune modulator, immunosuppressant, so it may put you at higher risk for infection.
Other
Yeah.
other infections.
So
And
somebody's saying that they were put on steroids because the person doesn't make cortisol. Yes, in that case, you need to be on a steroid.
yeah.
So it's always getting back to equilibrium, okay? So if you're short of breath, even though oxygen is oxidating and you don't want more than 21% unless you absolutely need it. So if you're short of breath and you need oxygen to get your saturation back to normal, then you take the oxygen. I mean, this is the point here is yes, there is some risk, but what are you going to do without it? You're going to be walking around with short of breath. You're not going to be walking around at all, right? Because you don't have enough oxygen. So we're always want to get you back to equilibrium, whatever you need to replace. We're not necessarily have if you're having a deficiency of it, then yes, replacement is absolutely necessary. What do I recommend for increasing acetylcholine? Well, the question is why do you want to increase acetylcholine? Acetylcholine is a neurotransmitter. It functions in the brain. It's implicated in Alzheimer's. That is decreases in acetylcholine. It's also responsible for a lot of peripheral functions. It's pretty much the main neurotransmitter in the autonomic nervous system. That's both parasympathetic and sympathetic. That's the end part, what they call the postganglionic. So there's like, I don't want to make it too complicated, but there's a couple of steps in between the main plexus and the effector organ where the communication happens. And the main thing is acetylcholine is responsible for communicating that last step. And that includes the adrenal gland, right? Because when you get the jolt of the acetylcholine, and there's also yes, I'll get to the motor pathway. Thank you, Andrea. I'll get to the motor pathway in a second, but basically, when the acetylcholine hits, that causes the action to happen. Whatever it is, if it's in the gut, it may be secreting more acid, or it may be increasing peristalsis, the motion of the gut to churn your stomach or move food along in your esophagus. The other place that is incredibly important, as Andrea said, is between the end connectors nerve and muscles. So myasthenia gravis is a big problem because there's antibodies to the acetylcholine receptor. So acetylcholine gets released, but it can't bind to the muscle, so the muscle contracts, and because there's an antibody preventing it. So the only way to counteract that is by increasing the amount of acetylcholine in your system. And the way that we do this in myasthenia gravis is by introducing a medication called an acetylcholinesterase inhibitor. So acetylcholinesterase sits between the nerve and muscle, and basically breaks down the acetylcholine once it does its thing. We don't want it to sit there forever, right? Because then you'll have tetanus, you'll have contraction in your muscle, you won't be able to release it. So there's a built-in mechanism to break down the acetylcholine and suck it back up to the prior nerve and repeat the process again. But by inhibiting this enzyme, acetylcholine starts to accumulate in the synaptic cleft and activates the muscle. So it creates increased strength when you have weakness. So mestinon is a big one, pyridostigmine. That's the medication that's often used for myasthenia gravis. Yes, it's been used for chronic fatigue. It's also been used in long COVID. It seems to help with brain fog and fatigue. But I urge you to be careful, as I said, with neurotransmitters. It's a very fine balance. Have you ever heard of organophosphate poisoning? They used to use organophosphates to weed, destroy weeds. That particular substance is a non-reversible acetylcholinesterase inhibitor. So it goes. I mean, you can't undo it. That's why this poisoning is so severe. You go into a cholinergic crisis, and you end up hospitalized and on the ventilator, and you have to wait for your body to kind of replace everything before it works again. So my point is you have to be very careful. Acetylcholine is good for you, yes, but too much can be bad for you. Depending on which way it goes, there's a lot of implications. So my point is don't mess with neurotransmitters unless you really know what you're doing.
And working with a doctor. It's a very delicate balance.
What about using metformin? I love metformin.
Yeah.
I love metformin for several reasons. Yes, it's an old school medication for diabetes. It helps reduce blood glucose, but it has some interesting side effects or functions, I would say.
Yeah.
I guess side functions. One of which is it alters your microbiome for the better. Let me say that again. It alters your microbiome for the better. So it decreases some of the species we don't want and it increases some of the species that we do want. We're not exactly sure how this happens. It may be creating a food source differential. But what's interesting about metformin, and this may be the way it works, and we don't know for sure, but it tends to reduce the incidence of long COVID. So if you take it early on in the COVID infection, you may have but it's about 41% relative reduction in long COVID. So I happen to like it a lot. Somebody is asking, let's see, Chloe. Chloe is asking, I'm guessing from Canada, is asking, is guanfacine the same as mestinon? No, it's not. They're completely different classes of medications. Yes, they kind of treat the same issue, but very, very differently. Guanfacine is a non-stimulant medication used to treat ADHD normally. It is a very specific alpha-2 agonist. So the prototype medication here would be like clonidine, which helps dilate your blood vessels and decrease your blood pressure that way. And it also, this particular one works in the brain. So guanfacine is helps with fatigue and brain fog. I know that it's been tried in chronic fatigue, and it's being tried in long COVID as well. Mestinon is pyridostigmine. It is a reversible acetylcholinesterase inhibitor. I know it's a mouthful, but basically it increases the acetylcholine in the synaptic clefts. And what it's meant for is, to treat myasthenia gravis. by increasing the amount of acetylcholine that's available to the muscle. But it also has some cerebral or cognitive function improvement as well. Let's see here. What all symptoms of long COVID do you treat? I treat them all. I mean, there's 203, different potential symptoms, and I treat them all by first determining which of the three causative factors is most prominent. Sometimes it's equal. Sometimes it's more mitochondrial dysfunction. Sometimes it's dysautonomia. Sometimes it's all dysautonomia. Sometimes it's all mitochondrial dysfunction. Um, and then basically do the treatment for the specific issues, targeting the cause rather than a symptom specifically. Now, for instance, if a person has mostly neurologic or psychiatric symptoms, things like neuropathies, anxiety, brain fog, that's when I select looking at vagus nerve stimulation and the stellate ganglion block, or my version of it. If you're having more issues with exercise, post-exertional malaise, exercise intolerance, fatigue, I may choose to treat the mitochondrial issue. I still evaluate all three things though: mitochondria, dysautonomia, and the gut dysbiosis. And I have news for you. Even if you don't have any gastrointestinal problems, you're not having any bloating, you're not having any diarrhea, you're not having any nausea or vomiting, you most likely still have a dysbiosis going on. This is due to the initial COVID infection. If you got this um, the vaccine instead, the dysbiosis may not be as severe as some of the other functional issues, but just about everybody has issues with the gut. But those are the three that I found pretty much kind of interplay to cause long COVID. And pretty much every single symptom you have in long COVID can be explained with those three.
Also, I wanted to remind folks that Dr. Groysman does a patient-centric approach, looks at each person individually, and does, a very thorough, comprehensive, what do you call it, clinical history. And he does not gaslight. You go some places and you're treated awful. That doesn't happen. And he's not only treats folks in Texas, Dallas-Fort Worth area, but now he's added the ability to treat patients around the world, working with doctors around the world, and in over 200 languages, right, Dr. G?
240, that would be on if we're doing like a teleconference or a teleconsult. And the website can be translated into about 100 different languages, including the new patient paperwork. So if you don't speak English, that's okay.
Right.
The website will default into your default language on your browser. So if you have German there, it's going to show up in German. If you have French or Hebrew, whatever,
Right.
it's going to show up in that language for you.
Yeah. And there's a ton of information on covidinstitute.org. You have to check it out. Ton of information.
Yeah, I add information there weekly as new stuff comes out, as things change, because they do change. And I try to keep all the information updated. I try to post things that people ask about frequently.
Yeah.
Um,
And I know folks have been asking for some of our meetings, podcasts to be translated to other languages. So I'm looking to see how I can get that done. It'll be interesting. I know we can. I know once it's transcribed and closed
I'm
caption.
sure there's a way to do it, like a dubbing it, so to speak.
Yeah, that, or at
I
least
don't
the
know.
closed captioning being put in multiple languages, making sure it's, all the transcription is correct. But many have kind of discovered us and your work and our research, and they can't wait to hear what we have to say. And we'll probably have to get like volunteer students who speak multiple languages to simulcast in like Spanish and French and just about at least some of the most popular languages. The other day, I had someone who was so interested in what you had to say, I was having to reach back, almost 40 years ago when I studied French to speak with them. And
Luckily, we have basically live translation or AI
yes,
that can help kind of stuff. And you can't. I mean, you could be proficient in a lot of different languages, but it's hard to be proficient in them all.
yes,
Let me talk about Epstein-Barr.
yeah,
A lot of people are asking about Epstein-Barr
sure,
virus. So Epstein-Barr is a DNA virus, and it is a herpes family virus, which means pretty much any herpes family virus is kind of permanently in your body once it gets in. And the reason that happens is because it transcribes itself into our genome and is able to reproduce at will. But usually, what happens is you'll have mono. A lot of people get mononucleosis, kissing disease, whatever it's called in your country, and you'll recover, and it could be 4 to 6 weeks, and you'll be tired for even longer than that. Which is why we think chronic fatigue is associated with Epstein-Barr, and then it goes latent. It just goes to sleep, and it's in there, but it doesn't really bother you because your immune system is keeping it in check.
yeah,
So let's talk about reactivated Epstein-Barr virus. So we don't know 100%, but we have a pretty good idea of what causes or triggers Epstein-Barr reactivation. It could be stress. It could be another infection. In fact, getting Epstein-Barr reactivation is one of the cardinal symptoms to know biomarkers to know that you have long COVID. It correlates about 96%. So if you have reactivated Epstein-Barr and you've had COVID, um, you pretty much know you have long COVID. There's this one study that showed this correlation. So let's talk about what happens when Epstein-Barr virus reactivates. Well, if you're healthy and nothing else is going on, not much. You may not even notice any difference. You may not have any symptoms at all. Now, if you have immunocompromised situation or even something like long COVID, you may notice that your lymph nodes around your throat, around your chin, around your neck get large and painful. Okay, so lymphadenopathy. You may have the same symptoms you did when you first had um, mono. You may have the same identical symptoms: the cough, the sore throat, basically all the symptoms. You can get the same complications with Epstein-Barr that you can get during the initial infection. Now, the one that we worry about is infection of the liver. You can get a hepatitis, viral hepatitis from Epstein-Barr. It can also cause meningitis or encephalitis. It can attack your brain. Now, these are very rare. I'm going to put it out there. It's not very common to see these other complications, but it's potential. I mean, Flu can do some funny things too. But when do you treat Epstein-Barr? When it's causing a problem. The reactivation can be treated. Most of the time, it's not. If you talk to a lot of PCPs and other docs, they're going to tell you that you can't treat the reactivation of Epstein-Barr or any of the herpes family virus, but that's really not true. There's several different ways to treat it. One is with herpes family virus antivirals. The big two are acyclovir and ganciclovir, but there's several others. So these are actually kind of different. They are a modified nucleotide, specifically designed to be incorporated into Epstein-Barr or any of the herpes virus genome as it's trying to replicate, and it basically creates a stop. It can't continue beyond that, so it can't replicate. So these work to stop a reactivated virus, but they do not stop reactivation. So you can take those antivirals as needed to stop it. But if it's not causing you a problem, then why are you doing it? Because anytime you take anything, there's always a potential risk. And I always want to evaluate, not in isolation, by the way, in everything. You want to look at your health and your medical status and everything else you're taking and see what the risk versus benefit would be. If the risk is high and the benefit is low or non-existent, then why are you doing it? So,
And don't you also offer some pharmacogenetics testing to? It's not always covered for every, insurance plan, but there is some of that information can help.
I mean, we do some genetic testing for that, yeah, but it's basically once per lifetime kind of thing, benefit typically. I
Gotcha.
don't really think this is going to help in managing this kind of infection. It helps determine if you have an enzyme defect or a genetic defect that's going to influence how you metabolize a particular medication. But
Yeah.
I don't think it's necessarily going to help in this case.
Right.
There's another medication that is being repurposed. Um, it's typically used to prevent platelet aggregation, dipyridamole. And this one in particular can prevent reactivation. Now, somebody who's continually getting severe reactions or complications from Epstein-Barr may need to be on this. Now, it is a blood thinner in a sense because it inhibits platelet aggregation differently from how aspirin does. But nevertheless, it can increase chances of bleeding, so you have to be careful and you have to let your surgeon know if you're going to have surgery. But that one in particular has been shown to prevent reactivation. So if you're on it, you're not going to get more Epstein-Barr reactivating. And it can also treat reactivated ones as well. So kind of dual purpose. There's other medications that work in a similar fashion, but those are kind of the big ones. And how do you know if it's reactivated? So there's several ways to check. What you're looking for is antibodies to different parts of the virus. And some of those are going to be positive for life. So once you've had mono, and 95% of the population has had mono, usually the young kids are the ones who never had it. But if it's going to always be positive for some antibodies. But what we look for is early antigen, and that's usually only positive when you have an ongoing infection.
Interesting.
Okay, so all these are going to be different antibodies, and there's 4 you need to check for. But early antigen is the one. Early antigen antibody is the one you want to look for. I guess a second way to look at it, you can look at IgM and IgG for part of the nuclear capsid. And if the numbers are going up, there's a chance that it's going to be reactivated. In other words, if you looked at it 2 weeks ago and you're checking it again and it's increased again, there's a chance that it's reactivated again. So there's a few ways to do it, but just having reactivation doesn't mean you need to treat it, only if it's causing you a problem.
And the symptoms they would notice would be
Well, like I told
the
you,
swelling and the
it would
swollen.
be similar. It could be asymptomatic, or it could be similar to the initial mono infection, or you can start having some of those rare complications where it's attacking your liver or your brain or your spinal cord, things
Gotcha.
like that. That's when treatment becomes required.
Gotcha. It's interesting you brought up the swelling of the lymph nodes, because that was a symptom I read about on one of the groups. Someone was saying, I have all of a sudden, this lymph node is so swollen and my eye is bothering me and I'm having trouble swallowing, just so many things that it reminded me of a lot of what we hear with long COVID, and just folks have to get with their doctor to get, assessed early as possible, to treat some of these things. And I'm so glad you exist, Dr. Groysman. I can't say it enough. I really am. Thank God for you. I prayed for you and you showed up. I keep telling my friends.
So I want to address the spike protein and the microclots. I know it's being mentioned a few times in the comments.
Yeah.
The spike protein, yes, it's part of the virus, okay? And it is produced after you've been vaccinated, which is the whole point of being vaccinated, right? Because you want to form antibodies to it and be protected. But it hasn't been proven to be a source of the pathology. So yes, it's part of the virus. Yes, sometimes we find it in circulation, but what you're getting tested for in labs is the antibody to the spike, not the antigen. So you don't really know how much of the spike protein is actually in your circulation. So what are we really treating? The hypothesis or the theory out there is that the spike is toxic and it binds to the ACE2 receptors, and it binds to endothelial cells, damaging them as well, which is where the whole microclot theory comes from. But these are just theories right now, okay? I can tell you what's out there, but don't take this as gospel or as peer-reviewed evidence yet. So people have used nattokinase, and they've used ivermectin, and they've used NAC to bind up, supposedly bind up the spike protein to eliminate it. A lot of these have been done in vitro, that means in a petri dish. And what happens outside your body doesn't always happen the same way inside your body. So you have to take that with some caution, a grain of salt. Nicotine was, supposedly loosening up the spike proteins from some receptors. I don't know if this is happening inside the body as it is outside the body. So I believe nicotine works in other ways, in several different mechanisms, and that's posted on the nicotine protocol website in my COVID Institute, COVID.org website. So if you go into treatments and go into nicotine protocol, you'll see it there. But I don't want people to focus so much on degrading, eliminating spike protein, um, and this whole microclot thing. I think those are incidental findings and not in any way causing long COVID. Regarding the sorry, I lost my train of thought. Um, Augmented NAC is, in my opinion, is a gimmick in how they formulate um, N-acetyl cysteine, but I mean,
I have read papers on NAC helping with reducing some of the fibrosis or scarring that happens in the repair process.
well,
But
what is
it's not
NAC?
alone.
It's
You know,
used in like things like cystic fibrosis,
yeah,
okay, to thin out the mucus and help that way. So it is an actual medication, even though it's available as a supplement.
yeah.
But
Ah,
it can
okay.
actually be inhaled and nebulized.
Oh, wow.
I guess what I'm trying to say is there's going to be a lot of there's a lot of gimmicks out there
Yeah,
that are there to earn your hard-earned money, and you guys are not working. A lot of you are not working because of long COVID, because of the COVID injury.
right,
I'm really trying to protect you guys from spending money just for the sake of spending money, for making these
right.
business guys rich.
Yeah.
Um,
There
there's a
there
lot
was
of stuff out
there
there. And it comes out almost every day. I mean, I see new
yeah.
stuff every day come out, and I'm doing a face palm a lot of times. And I'm saying, surely people aren't going to fall for this. And sure enough, it gets brought up in the group the next day. Um,
Interesting. I found it's not one thing that will solve this problem. It's such a comprehensive and uh, multifaceted syndrome. You know, so many things are going on that have to be paid attention to, and the gut is a key component of it. You can't do just one thing and ignore the rest, and the order is important, like what you said. The order of how you treat things is important, and you have to work with your doctor. You know, your levels can change as your your gut health changes. You know, as your system changes, you may not need as much medication, and sometimes too much of a good thing can really be damaging. Like, you know, taking, I was like, my nephrologist was like, 1,000 units of vitamin C. What? You know, he was worried about it hurting my kidneys, for too long. I didn't take it forever, that long. But I was like, I myself, I was researching all these papers to see what are all the things out there that will support my immune system, give my body what it needs to repair itself, and rely on that until I find a doctor like Dr. Groysman. I mean, it was such a lonely process that so many are still going through till they find you, like wondering, what can I do to stay alive, to keep myself healthy
and you got to
and
remember, all
make
this
it.
is a work in progress. I mean, things
Yeah,
change every week. New information comes in, and of it constantly.
yeah.
It's not whatever I learned in med school or residency or whatever, and
No.
that's what I use now. I didn't learn
Yeah,
any of this stuff. Any of this stuff.
yeah,
All this is new. And with new conditions, new illnesses, it can be a bit of a guessing game um, until new information comes out.
yeah,
So, but I'm very cautious about what I recommend, And even if there's anecdotal evidence supporting something, I tend not to recommend it until I see some
Evidence-based.
empirical evidence.
Yeah.
I don't push any particular product or brand or anything. I always think it's a red flag when somebody does. I don't think augmented NAC is anything special compared to regular NAC. I really haven't seen. It's N-acetylcysteine. It is a modified amino acid. So cysteine is an amino acid, and my point is what are you augmenting? Is it worth the additional cost? I can't answer that for you. To me, it seems like a gimmick.
You'd have to wonder, is it a more, better absorption? I mean, I don't know the specific product. For me, I got, one off of a website that, made other supplement products, and they were listed as what's that G? They have like certifications that uh, they make their products to a certain what is it, quality, quality control. My battery's also low, so I apologize if I
Well,
just
we're going to
jump
be
off.
wrapping up anyway
Yeah.
here in a few minutes. But Peter is asking about tinnitus from vaccine. Yes, I have seen a significant high rise of tinnitus and other neuropathic symptoms coming post-vaccine. If you listen to the CDC, those are all rare. All complications from the vaccine are rare. I mean, it barely even happens. I mean, it's almost not worth talking about.
Okay. I experienced it.
I'm not buying it.
Yeah.
I'm not buying it. I think there's more than a significant percent of complications. Now, I don't know if eventually they'll get it right and get these vaccines properly made. And the biggest thing I'm concerned about, obviously, is the DNA contamination. So, if you understand how these vaccines are made, they're made by bacteria. So they implant a segment of the spike protein or the spike protein. How Novavax is a little different. I'll talk about Novavax in a second. But when they implant the DNA part of it, and then they have it transcribed into RNA or mRNA, and then they modify this into modified mRNA or modified RNA. But and the modification happens in one of the nucleotides. It makes it less harder, more resistant to degradation. Now, normally, if you have mRNA, it breaks down within 1 or 2 minutes. It's purposely designed this way. It does what it needs to do, and then it's destroyed. But a modified RNA hangs around longer, way longer. But I'm getting off the beaten track here. What I'm trying to say is that once it's transcribed, what's supposed to happen is the DNA that was used to make the mRNA is filtered out and removed. But that is a more expensive process to do. So what several companies decided to do instead is to basically introduce a DNase and break the DNA into smaller fragments. So instead of a sniper rifle, now you have a shotgun, and all these little bits have a potential to to enter the nucleus and potentially become incorporated into your genome. Now, where they get incorporated is what matters. I'm not saying this happens very frequently. I'm saying there's a possibility for this. And if it inserts itself and causes a gene that's normally inactive because it's been off, for 10,000 years, all of a sudden to become active, and now you're producing something you shouldn't be, that could potentially cause a problem. Or it could turn off something by inserting itself between a functional working gene. Now, luckily, our genome has a lot of inactive process, right? A lot of it is not active or useful. So if it inserts there, it's not really going to do a whole lot. But if it inserts into something that's important or critical, you may have a problem. Now, this is separate from long COVID. This is talking about causing a problem down the line, like cancer. So let's talk about Novavax. That particular vaccine uses a protein segment. So they basically just take a spike protein and put it with an augmenting molecule that makes your immune system super active, which is what you want. And you're basically getting a load of spike protein plus something to get your immune system angry. Now, when Johnson & Johnson and Janssen did the same kind of strategy, there was some issues with complications, correct?
Yeah.
And it was pulled from the market. Janssen was the one done in Europe, and J&J was the one done in the US. Novavax, I don't know 100% of kind of the current safety profile for it, so I'm not going to comment. But it uses a similar idea, though, to what J&J and Janssen did. So I don't particularly think the vaccines are not every vaccine. I'm talking about the COVID ones.
Yeah.
Okay, I'm not anti-vax. I got my flu vaccine 2 weeks ago, and I know I got a lot of flack for it on Facebook. My own group.
Yeah.
I got a lot of flack.
We care about
I,
you. We need you to stick around.
But flu can be very dangerous too in certain cases. But my point is right now I have a hard time trusting the vaccine companies that are making the COVID vaccine in general, because it seems like some corners were cut, and safety should be priority number one above anything else.
Yeah.
And I feel let down. I feel betrayed a bit.
Yeah.
And I feel like there's some media suppression of the complications and all the problems that are happening around these vaccines. So right now, I'm not a big supporter. Now, that may change in a year or two, who knows? But I'd want an independent analysis of the vials. I want to see what's in there, and when it's safe. But yeah, I'm a bit disappointed. I have to tell you, as a medical provider, I'm a bit disappointed in how this whole thing was handled with vaccines.
They have a lot of research to do to look at folks, if their stem cells have been affected, to see how their bodies have changed post-vaccination. It's all new, and we need those studies to be done.
I'm going to wrap it up on this one last comment.
Sure.
From a Facebook user saying that her PCP said that it's all in her head. This is a physical illness. There is definite pathology happening. Now, you can certainly get anxiety and depression from long COVID, but it's not all in your head. I mean, I remember hearing this when I was training for not chronic fatigue, for fibromyalgia. It's all in your head. It's all in your head. And that's kind of what got me thinking, like, there's a lot of gaslighting in medicine. And I said, I'm not going to do that. And this was, this was early in my training, but my point is that just because you don't know what's going on does not mean it's imaginary
Right.
or in your head. And let's finish with that. And we are going to do this every 2 weeks, and we're going to alternate the time because I'm having a lot of European people asking to do it earlier.
Okay.
So do it at 10 a.m. on Sunday, one week, and then 2 weeks later we'll do it at 3:30,
Okay.
and so forth. And we'll flip
Okay.
to make it available for
That's a great
I
idea.
get it. And I do understand that in the medical community, if you're a nurse, if you're a doctor, Marina is just saying that she had to get vaccinated in order to work. Same here.
Yeah.
I had four COVID vaccines, all Moderna, and let me tell you, I'm not just a doctor who treats these. I've actually suffered from both long COVID and vaccine-related issues. And no, Peter, don't interpret. There's nothing to be done. I'm sorry, I just can't get to everybody's question. I will do my best to try to answer in the future. Okay. There's no new treatments right now yet for tinnitus, but I guess what I'm trying to say is to protect your job. Yes, sometimes you had to do it in order to be able to make a living. You had to get vaccinated to make a living, and I've experienced both long COVID and vaccine-related problems. Now, granted, it was nowhere near as severe as some of the folks that I treat and see in Facebook, but nevertheless, I had it, and so I know where you guys are coming from. Not just as a treating physician, but also as somebody who suffered with it.
I do want to just make one quick thing about the tinnitus. It was very severe for me in the beginning at the worst of my symptoms. I'm sorry, there's a fire truck in the background. But over time, as my overall health improved, the tinnitus got better. But at one point, it was so severe, so altered that I questioned what I was hearing. I was like, did somebody just bang a gong next to my head? I mean, the sounds were so altered and loud, and the buzzing and the it was like a kettle, like a hissing sound all the time. It's improved. I don't hear it much on my right ear anymore, just a little bit in the left. But when you take care of your gut brain immune axis, that's my theory. Okay, when you work with your doctor and he treats the root cause of what's going on, not just the symptoms, like Dr. Groysman, he goes to the root cause. You take care of these things, and I wish I had known about vagus nerve stimulation and treatment for that. Would have helped me out a lot quicker than just.
You know what, Amira?
Yeah.
I put this together. I put this together more than 2.5 years ago when I was starting to read about vagus nerve stimulation in the treatment of ulcerative colitis, vagus nerve stimulation in the treatment of migraines, vagus nerve stimulation in treatment of arrhythmias.
Oh.
So I started reading into it more, and I'm like, what? Okay, so this is correcting a part of dysautonomia, and I think long COVID was caused by dysautonomia. So why don't we try it? And there's been hundreds and hundreds of people that have recovered from long COVID. I mean, completely recovered just by using a vagus nerve stimulator. And not everybody, of course, because like I said, it's not just dysautonomia. Some people have the mitochondrial issues.
Right.
Other people have the gut dysbiosis that is mainly responsible. Um, Yes, this is recorded. Yes, this will be posted in the group as a recording in a few days. Just give me time to download it and stuff. We're going to be doing these every 2 weeks. And yes, I mean the TENS unit, but you can also use a dedicated vagus nerve stimulator. I was the one that came up with the protocol by looking through like about 7 different studies, trying to figure out what was the best setting. And I finally came up with a composite protocol. I mean, there was like 10 different protocols out there and different settings. So I just had to decide on kind of what I wanted to set mine at. If you have Christina, hang on, Amir. Christina, if it's one-sided, there's a much better chance of treating it with a stellate ganglion or my modified version of it. So if you'd like to do that, just give my office a call. I have treated several with one-sided. It seems to work sometimes better for one-sided than bilateral, but we've had several that recovered with the bilateral too.
If some folks have heard that like whooshing sound on one side, would that, that was one of
if we're talking about whoosh, 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 that could just be a blood vessel, like an artery. But if it's ringing, if it's buzzing, if it's, I mean, tinnitus has different ways it could present. So if it's constant, I think it's less likely than, I'm sorry, if it's whooshing, it's less likely to respond than if it's constant or buzzing or ringing.
Gotcha.
All right. Why don't we wrap it up with that? And I will see you in 2 weeks. And if you like to get Remy or the other gals involved, just let me know.
Sure. Will do.
Hopefully you'll get your natural gas situation situated.
Yes.
And I'm already hearing my wife calling, so
yeah.
I'm going to run, okay?
All right. And Happy New Year, everyone.
Happy New Year.
And healthy New Year to everyone. And be sure to go to covidinstitute.org and follow us, Long COVID Association. Follow us on your social media. And 2 weeks from now will be the 21st. So at 10 a.m. Central Standard Time, January 21st, we'll be back again.
Yep. All right. We'll see you again. And you can always contact me through the group as well.
Yeah. In multiple languages.
Yes, in multiple.
How awesome is that?
I really do got to run because I'm going to get in trouble.
All righty. Take care now.